hope you are doing good. Guys, this is once again, welcome back to the OMR series. And this is an early pregnancy module station, which is once again a patient simulated task. This is one of the commonly tested tasks which could help you to prepare better for the exam. Okay. Thank you, Aisha, for joining once again. So let me keep a timer and then we can start. Yes. Shall we start, Aisha?
Yes.
Mrs. Jane Doe?
Yes.
Hi, this is Dr. Sowmya, one of the doctors in the clinic today. So I know that you are here to discuss the management of your pregnancy. As we are meeting for the first time, is it okay if I ask you a couple of questions?
Yeah, I'm really worried. I got a ultrasound done, and I'm just worried about the pregnancy.
Yes. Yes, Jane. So I can see that you are really worried about what is going to happen, but I want to make sure that you are fine and few things to come to your planned management. Okay. So I am aware that you are 7 weeks pregnant and the pregnancy is in tube. So are you aware of this pregnancy? Has anybody explained to you about this?
Yeah, they just give me an indication that it's not in the womb, but outside the womb in the tubes. But how to go about the management, it's really worrying me.
Yes, Jen, please don't worry. So I am here to help you with that. Jen, I just want to know, like any problems do you have got during this pregnancy? Right now, do you have any tummy pain or giddiness or anything at all right now?
A little bit of tummy pain, no bleeding or anything, but I'm worried, I have two miscarriages earlier.
Mhm.
Uh, that was one was at 5 weeks, another one was 6 weeks, and I'm thinking this also will end up like that. And it's a surprise to me that it's not even in the womb and it is in the tubes. I'm really worried. I don't know how to go about the management.
Yes, Jane. I'm really sorry. This must be really difficult because you're going through a lot. And we will be making sure to help you to understand in the first place what could have caused and how we are going to help you with this as well. Okay. Jane,
Mm.
you mentioned you have a very mild tummy pain and you don't have any other issues. Like, why did you go for the scan? Was it advised by your GP to get the scan done?
Yeah, because the first two were early miscarriage, and I had pain. He said, "Let's do a ultrasound get done."
Okay.
When it was done, I don't know. I'm just worried.
Yes, I can see that you are really worried. And like, because this is a third pregnancy, of course, first two leading to miscarriages as well. So just to understand, like these miscarriages are managed with the tablets, right?
The first 2 years were managed with some
Okay.
tablets. I'm hoping this one will also be managed with the same.
We will come to that. We will come to that. Okay, Jean. And like, are you generally fit and fine?
Yeah, I'm feeling fine.
Okay. Have you undergone any other operations on your tummy or pelvis?
No.
Okay. And have you undergone the smear? The first one, could you get that done as well?
Yeah, they sent me an application and went for it, and it's normal.
Okay. Are you aware of your blood group?
Yeah, it's A positive.
Okay. And I need to ask you a couple of questions about your life, private life, which is important for me to, for the management. Do you smoke?
Yeah, I do smoke.
Okay. So is it like, just to understand, like, have you anytime thought of quitting and anything, any counseling you have gone through?
Not yet. I don't think it is a need for me.
Okay. The only thing is, Jane, because once the pregnancy is in tube, that for we have seen that women who smoke will have a probability of having this more. So that's the reason I was trying to talk to you. Probably if you could think of quitting, that would be really good.
Oh, really? Is it okay? I can think of that.
Yeah. And like, I just want to know whether have you ever been treated for sexually shared infections before?
Yeah, when I was a teenager, I had some discharge, a very bad discharge, for which I was treated.
Mm. Okay. And as well, whom do you live with?
I live with my partner.
Okay. Is he supportive?
Yeah, it's quite supportive.
Okay, that's good to know. And do you have any allergies?
And not that I know.
Okay. Okay, Jane. Thank you for letting me know. Let me quickly summarize before we before we discuss the management part. So you're 25-year-old and this is your third pregnancy. First two are miscarriages, which are managed with the tablets. This pregnancy, you are into it 7 weeks. You have already got your scans done. And you have been treated once for sexually shared infections. Other than that, you are not allergic to any medications and you do smoke, right? Fine. So, coming to this, Jane, the probable options in front of you is because the tube, I hope you have been explained, but let me write a diagram as well for this. So, basically, this is the womb in which the pregnancy has to be there. But at times, what happens, the pregnancy can actually stay back in the tube itself because this is where your ovary is. So ideally, the baby should be formed here and it moves back to the womb. But at times, the pregnancy tends to stay back here. Okay. And because it is here, obviously, we cannot expect it to grow to the 9 months and deliver because this is not in a normal position. This is in the abnormal position. Hope
Yeah,
this is clear.
yeah, doctor. As you said, it usually travels from the tube to the womb. Why don't you move that which is there in the tube to the womb?
Actually, the thing is, this pregnancy is implanted here, so it cannot be moved. Okay. So generally, but the physiologically, normally it has to be moved from tube to the uterus. If there is any problem with the tubal health, that is why it doesn't get moved here. And manually, we cannot move this. That is not something which we can do. Okay. And
Okay.
what happens is if it tends to remain here for a longer time, this grows bigger and it can rupture, which can lead to life-threatening bleeding and risk to you as well. Okay.
Mm-hmm.
And since I'm glad that you have come at the right time, and there are a lot of options for the women who come with a tubal pregnancy. Okay. The first option is based on the things, we can let the nature take care of it. However, this is not possible in your case because we already see the baby's heartbeat. Of course, we need to do the couple of blood tests like your pregnancy hormone will be doing. We'll be doing the full blood counts of you and how the liver is working. And also, to some extent, the kidney test we need to be doing as well, and your blood grouping and RH typing as well. And one thing I forgot to ask you, Jane, was whether you have any reservations for the blood transfusion if it is required.
No.
Okay. Thank you. So the options after the test, we really need to run those tests to make sure that you are okay. And waiting for the nature to happen won't happen in your case because the pregnancy has grown really big. And for other women where we do not see the baby's heartbeat, we do give the injections to make sure that this pregnancy gets absorbed. And for women in your place who have got already the baby's heartbeat, who is 7 weeks pregnant, we offer them operation, which is a keyhole surgery. Am I clear?
Oh,
Okay.
oh. So you mean to say the medications won't work with this type of pregnancy?
Yeah, it is unsafe to give medications at this point of time because once the baby's heartbeat is there, means the pregnancy has grown beyond the medication where it can work. Okay. And the keyhole surgery is something which is very gold standard and which could help us also to have a look into the other tube as well. And once we do a keyhole surgery, there are two things which we do is if the pregnancy is in the left tube, we'll always see the health of the right tube. If the right tube is healthy, then based on the contralateral tube healthy, either we will be removing the tube or we will only be removing the pregnancy. Okay. The reason why we remove the tube is to prevent the further recurrences. However, if the opposite tube is unhealthy, then we only remove the pregnancy and leave the tube back. Okay. And as even after the surgery, we make sure that we follow you up with a pregnancy hormone to make sure that the pregnancy hormone is subsided and the whole of the pregnancy is removed as well, because that is something which we will be doing based on what surgery we do based on that.
So you mean to say if the tubes, since I had some infections during my earlier days, if my tubes are not good, then we might have to remove the pregnancy tissues.
Yes.
And if you follow up with the hormones, and if it doesn't come to normal, what are you going to do?
See, generally what happens, the very, very rare thing that like when compared to the other treatments, generally the pregnancy hormone falls. But if it doesn't fall, then we need to look into why this is increasing or why this has not decreased. And we will take the consultant opinion and we'll give you a dose of medication to actually remove those residual tissue as well, if at all, if that happens.
Okay. Mm-hmm.
And
So
also,
what if both tubes are not healthy? Then how we go about the future pregnancy? As you see, I have two miscarriages and now it is an ectopic.
yes. See, if at all, if we feel that there is a both the tubes, of course, we need to, after this pregnancy is treated, we will be giving you the time to check the tubes afterwards as well. But if we find the tubal blocks, then we will also discuss with our consultant, and probably the IVF would be the best choice for you, if at all, if this happens, like bilateral tubal blocks are there. Otherwise, I don't think so, because you are able to become pregnant. However, there is always a possibility of this happening again. So probably we need to look into the causes. Once this pregnancy is taken care, we need to look into the causes why this happened and take it from there. Okay.
So if I go in for IVF, what are the chances of success?
Okay, I think we are actually discussing far off, but I would still tell you, like, generally the chances of IVF is 1 in 4. The success rate is always 1 in 4. And I think, Jane, we would discuss that in the coming probably visits. I think that could be the best way forward, because we are we really need to take care of this pregnancy. And of course,
Yeah.
we provide you the information through the leaflets and the GP letter as well.
Okay.
Okay, yes, Aisha.
Yeah.
We're done with the time. Okay.
Okay. Okay. So everything went well, I think. The treatment part, laparoscopy, I think we can even say that about the how laparoscopy is done.
We could, but probably because this is not a consenting part, that's why I didn't keep it very this one, because I know that I have to. She might ask the complications and all. Like, probably I could have just told her like what we expect. That's why I wrote the diagrams, because I thought that's the easier way to put it across.
Yeah. Yeah.
You
So
mean to
how
say the
to
complications of laparoscopy?
no, how do you put the ports and cuts in the tummy and then we
Yeah,
take
probably
it
I could have,
out? Yeah.
yeah. Because of the shortage of the time, I knew that I won't be able to reach the end. So that's why I moved
Correct.
forward. Yeah.
Mhm. Okay. Rest, I think everything was fine. And I, as a role player, asked some questions which were not in the stations, maybe about the
Well,
IVF and
no, that's it.
fertility center. Yeah, one sentence would have been enough. We'll refer to the fertility center, and they will take care
Yeah,
from there on.
yeah. And the thing is, for me, my reflection is, I think I wasted a little bit of time in this. Probably I could have cut short at 1 minute, because I could hear myself repeating twice the same things about miscarriages. I told myself,
Correct.
probably that
Yeah.
could have been the best bet. And of course, like the patient asking about whether this can be moved back. And I wanted to make sure to make my point that this is not something which I'm going to do. I'm not going to, we cannot put back this as well. And also medical management is something which I clearly wanted to say that this is not allowed.
Correct.
Yes, and of course, fertility concerns, the tubal block, basically, even after that, there is a recurrence. And, like if there is a proximal tubal blocks also, I don't think so. IVF could be, they could already always opt for, because there is a funding and all that, right? So ideally, there is, in the next pregnancy, she has to be making sure that she will come in the first, this one only, and see how it goes. It's all depends on what happens to this tube this time, right?
Correct.
Okay. Yes, Aisha. So the competent candidate, I think, basically STI history and fertility concerns, complete risk assessment, explaining the diagnosis is very vital to understand, and treatment options. Yes, explaining the treatment options, what doesn't suit her is important. Empathy, reassurance, and professionalism and communication. I think basically you have to, even I felt that I brought my consultant very late. Ideally, you should have brought your consultant way before. The gist of the station is to not to allow her to have a medical management. Of course, you should figure out the reasons for her recurrent pregnancy loss. But that pregnancy loss, ideally, it has happened at 5 and 6 weeks. So we have to investigate whether this has probably APLAS and partner change and all that we need to be thinking. But if we go in that direction, then things could be very different, and I will not be able to finish the ectopic pregnancy. I had those in mind, but you could quickly move forward. You can put a sentences understanding that we really need to do a couple of tests to understand why the previous losses, and this also we would be keeping in mind. So that's something which you need to think of. And apart from that, I think this is probably in this station, they quickly move to the management and ask you about how the laparoscopy is done, as Aisha was mentioning. So you need not go into a lot of depth, but you could say that there will be cuts, and you need to have a closer look of the camera to see the tubes in the ovaries, and probably if then you can take it from there. So, and complications, unless she has probably if she had a previous surgeries, multiple surgeries, you could think of bowel and the bladder injuries and all that. Otherwise, unless it's a consent for laparoscopic surgery, don't go into the depth. Okay. So I hope these stations are helping you to do better, and these are all the previously exam tested tasks. So there could be twists and turns. The role player can say you a lot of things. The role player expectation could be very different. So don't go with an assumed feeling. Just go with an open mind, and then probably you would be able to do the best. Okay. Thank you, guys. Thank you so much.